Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Julio Sorblanco, and I will be the facilitator for today's session. This ECHO is brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well, Texas, in collaboration with the UT Health San Antonio ECHO program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions or having connection issues, please chat Echo IT Cato for assistance. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage joining by video and using the chat and/or raise your hand feature to pose questions or share perspectives throughout the session. And as a reminder, these sessions are being recorded and will be shared on our website. To ensure privacy, no personal health information is allowed at any point during the session. This includes client or patient names, addresses, birthdays, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask you to complete it as it provides feedback on how to refine these sessions to better address your priorities. We're also approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credential. Finally, ECHO is an all-teach, all-learn environment, and we do encourage everyone to participate in the conversation and raise questions. With that, we'll go ahead and move on to some team introductions. First up, we have Jeremiah Golka.
Hi, everybody. I'm Jeremiah Golka. I'm Executive Director of the SHIELD Training Initiative based out of Northeastern University, and we provide occupational health and safety trainings for law enforcement and first responders and folks across the criminal justice system to help improve their effectiveness in their encounters with people who use drugs and reduce their burnout at the same time. Looking forward to the presentations today.
Thank you. We also have Brandon Del Pozo.
Hi, everybody. I'm Brandon Del Pozo. Thanks for the intro, Julio. I'm an assistant professor of medicine and health policy at Brown University. I was also a police officer for 23 years, 19 in the New York City Police Department, and 4 years as chief of police of Burlington, Vermont. So always great to be here.
Great. And we also have Cynthia Mendiola.
Good morning, everyone. Happy to be here. My name is Cynthia Mendiola. I am a retired federal probation officer. I've worked in the criminal justice system for 34 years. Enjoyed every bit of it. My specialty was in substance use disorders and mental health. And I am a trainer and coach currently in core correctional interventions, and I'm looking forward to this presentation.
Thank you. Our case presenter for today is Johnny Hatton, RSPS and Reentry Support Peer Specialist.
Hi, everybody. Great to be here. My name is Johnny Hatton. I'm a Recovery Support Peer Specialist and Reentry Peer Specialist with the Abilene Recovery Council. And so all that means is that I get to leverage my lived experience to help other people who are in recovery and reentering society from incarceration.
Thank you so much. And our didactic presenter for today is Corrina Lopez.
Good morning, everyone. My name is Corrina Lopez. I am a supervisory probation officer in the Western District of Texas in San Antonio, supervising a team of about 6 officers specializing in co-occurring disorders, but also with gang ties and numerous other issues that our individuals on supervision encounter as they release back into the community. Thank you for having me this morning.
Thank you for being here today. And with that, let's go ahead and get started with our didactic presentation. Corrina, once your slides are being shared, feel free to take it away.
All right, thank you so much. We'll be discussing this morning as individuals on supervision acclimate back into our community and what it looks like for the reentry needs of those individuals with behavioral challenges. Next slide, please. Some disclosures to think about here is all speakers and all members of the planning committee have no relevant financial relationships with a commercial interest to disclose. The views expressed do not necessarily reflect the official policies of UT Health San Antonio, the Department of Health and Human Services, or Texas Health and Human Services. nor does mention of trade names, commercial practices, or organizations imply endorsement by the US or Texas government. Our learning objectives for this morning are 1, to explain the release planning as transitioning steps in the process of reentry for incarcerated persons who use substances. 2 is to describe the role of a probation or parole officer in the reentry process. And 3, explain the individual assessment of needs used with incarcerated persons and explain why it's important. Next slide, please. Our agenda is, of course, we had introductions, is looking at research, the investigation of the release plan when it comes to the family, release planning as the individual releases back out to the community, what our officer's role is, individual assessment of needs as the person comes out into maybe an RRC or they walk out of the facility into supervised release, and some final tips and takeaway why the reentry process is so important. Next slide. The power of research. Next slide, please. Research indicates that many of our persons under supervision, formerly known as offenders, who violate their conditions do so during the first 6 months of supervision. It further shows that it is those individuals received for supervision after serving a period of incarceration who are most likely to incur violations. That's why it is so essential. I remember Ms. Mendiola telling me at my infancy of starting my federal career, reentry starts at sentencing. We basically need to start looking at individuals, why they committed the crime, what got them there into the criminal justice system, and how we will make them successful as they reacclimate back into the community. The officer's role at the pre-release stage is to maximize opportunity for a safe release. That is inclusive of their home environment, implement a well-constructed supervision plan at the earliest possible time so they can reach success, and promote a continuity of services when it comes to substance abuse, mental health. It may be job resources. It may be a vast number of other resources as you start to interview that individual. Next slide. The objective is to have as much of the supervision structure as possible in place prior to that individual releasing. That's why it is so essential for those collateral contacts with family members, with the Bureau of Prison, the halfway house, anybody that you can speak to that has had a role with that individual to assess what their needs are going to be. A lot of times what we find is the information in the pre-sentence investigation may not match what those needs are as the individual acclimates back into the community. That's why case planning is so essential for that individual to become successful as they reenter back into the community. All release planning activities are to be documented into that officer's file. Basically, if somebody else were to pick up that file, we want to follow the story as to how that officer is investigating the reentry process. We want to know what exactly has been done for that individual. If, for example, they violate their term of supervised release, we want to notify the court exactly what has been done for them and what can we continue to do for them in order to promote success. Next slide, please. Release planning for the incarcerated person coming to supervision after a period of time of imprisonment. A lot of times what you'll see is that individual maybe has done maybe a year, maybe 3 years, maybe sometimes 15 or 20 years. So acclimation for individuals is going to be case specific. So what may look like reentry for an individual that has done 1 year will be vastly different for the individual that has done 15 to 20 years. So that officer role is going to take patience, perseverance, and just being open to meeting the person where they're at. And everyone's learning capacity is different. So release planning programs throughout the period of imprisonment is a joint collaboration with not only the institution, but also with the RRC, with family members, with collateral contacts, with significant spouses that maybe they had in their relationship, anybody that you can contact to get information of what that person's needs are. The person under supervision develops a proposed release plan with their BOP case manager. A lot of times what happens once that officer gets that release plan and we go out and investigate, it may not always be a healthy environment, or the person's family may not want that individual anymore. They've burned the bridge. And that's when it becomes a collaboration with that BOP case manager and the individual to find a healthy environment for that person to come back out into the community. It may look like an RRC placement, or it may look like a sober living, or we may try finding a family member that will actually take the individual to promote success in their life. The probation officer investigates the person release plan and either approves or can modify or disapprove that plan. So it's a joint collaboration that's going to take some time to develop with that individual, because maybe they were hoping to go back to mom's house and mom cannot handle if that individual may have mental health or substance abuse needs. And so then it's the officer's responsibility to collaborate with that case manager at the BOP and the individual to find a healthy environment for them. Next slide, please. The officer's role as in our office is basically supervision release planning and filing that final progress report with the BOP, letting the BOP case manager know what our investigation results were, and if we need to modify or look at alternatives for placement. We look at different things. We look at the PSI, we look at the BOP computation list, we look at any type of issues that they have been involved with the BOP, whether if not there's been drug use within the facility, mental health issues. So we're taking everything into a big picture and assessing what those needs are going to be as they transition out. What kind of services are we going to have to match with that individual? And we're luckily enough to have an office environment where we have contract providers that we can easily transfer that individual from the BOP into our contract specialties, which is for mental health, substance abuse, co-occurring, whether it's anti-abuse for alcoholism, or Trexan for opiate dependence. So it just depends what that individual is going through at the time. Next slide, please. Once all these documents are received and the officer is able to go through all the documents and staff with the BOP or the RRC staff member, officers should determine why any individual not being released through a RRC was denied placement through an RRC. What we see a lot of the times, individuals will transfer from the institution to an RRC halfway house, which is the most positive thing I think can happen for an individual, because then that gives them time, whether it's 6 months to a year, to acclimate back into the community. And they can get a job, they can start saving for an apartment or a sober living house. But we do have those instances where individuals are released straight to the street. And sometimes you're like trying to put out a fire, because then you may get an individual that is homeless and you're trying to sustain a safe environment for them. They have no family support, so you're the only support system that they're going to have, and you're trying to acclimate them back into services. And sometimes they walk out of the facility without any of their mental health meds. So it is a race to the finish line to try to get this individual back to services to keep them grounded. In any case, officers are to commence their pre-release planning after all relevant information has been reviewed. And sometimes there is no pre-planning. They're in your office and you're doing the pre-planning there. Next slide. A lot of the tools that officers will use as individuals acclimate back into the community, and if we have that benefit of doing pre-work at the BOP side of it, we'll use a treatment screening questionnaire, which will take the PSI and all relevant BOP documents, plus do a personal interview with the individual to assess where they're at now. And a lot of times what we find, they may not have given the full truth at the pre-sentence investigation stage. So you find out a lot of new information, maybe substances that they were actually experimented with, or they were addicted to, or maybe while incarcerated that they did continue to use. So we're actually able to assess where are they now and how do we help them moving forward. For individuals that have limited drug history, we can use the SASI, which is a substance abuse subtle screening inventory to determine whether or not there is a substance abuse issue. And those may be for your lower individuals that maybe have a DWI, or they just came into the federal system and have very limited substance abuse or mental health issues, and we can determine whether or not there is an issue. And of course, psychiatric evaluations, referring out to Center for Healthcare Services or Crosspoint that does our contract evaluations to determine if there is a mental health need for that individual. And some community resources that are valuable for the officer to keep abreast of is we have federal contracts with Lifetime Recovery, which does our substance abuse treatment. We have mental health treatment and our co-occurring disorders treatment. We just got a new provider, which is Continuum of Care, that just came on board with us. So they're a new treatment provider that has never worked with our population. So we're going to be taking baby steps with them. So we're excited that they have accepted the contract, and we'll have a co-occurring disorder program again. Our psychiatric services are with Crosspoint and Access, who do our psychiatric evaluations and medication monitoring for us. And of course, we have our halfway house, which is Crosspoint, and we utilize a lot of the sober living houses through Oxford. And then we have River City, who does our Trexan, Antabuse, and Suboxone treatment, which I believe officers have used Be Well for the medication assistant treatment programs. We utilize a lot of the DWI programs with DWI education, victim impact panels. Our residential treatment contract provider is through Senecor. We have facilities in Waco, Austin, and San Antonio right now. So all over the district, we're able to place people if necessary. We have our reentry work initiative through Goodwill and Alamo Workforce. We have a partnership with Goodwill, which they have their Proud program, which individuals are able to access work initiatives as they transition out back into the community. And then officers also do have cognitive behavioral treatment programs. We have a CMVC curriculum, which officers are able to take sessions from that curriculum and work specifically with dynamic risk factors with that individual. And of course, relapse prevention strategies that are continuous throughout the supervision process to ensure sobriety. So officers carry many hats, but reentry is the most important. And the relationship that officers develop at the onset of supervision is vital, because that's where you develop the trust with your individual. And that's where the true work begins, assessing their needs, acclimating them back with their support system. If they don't have a support system, creating those initiatives for them with stability in job, stability in treatment services or mental health services, and then finding pro-social activities that they can engage with to keep them out of trouble and out of the criminal justice system. So I'm very proud of the work that our officers have done. We are in a stage where we are highly encouraging core correctional practices, from assessing the individual with our PICRA assessment to engaging in CNBC and STAR, and then really working with individuals when it comes to the dynamic risk factors of social networks, education and employment, drugs and alcohol. So a lot of those factors definitely take a lot of work from the officers to ensure that we meet them at the finish line. So we don't want to revoke anybody, but sometimes that does happen where we have to engage in the revocation process. And a lot of times it's for that safety of the individual, to get them cleaned up and then look at modifying their supervision, whether it be for residential services or placing them back in the halfway house to create stability. But definitely our officers work very hard through the reentry process. And as a supervisor, I'm very proud of the work that they've done. Next slide. And that's all I kind of have, guys. If you have any questions for me, I'm happy to answer them.
Thank you so much, Corrina, for this great presentation. And yes, with that, I would like to open up the floor to our learning network for any questions that you all have for Corrina about her presentation today. Lindsay, I see you have your hand raised. Go ahead.
Yeah, so and I came in late, so I might have missed it, but do y'all have anybody on methadone? Or is that something you offer?
We do not encourage methadone. Sometimes what will happen, individuals will go out and they'll place themselves on methadone. We would like individuals to be on Trexan or Suboxone. We have seen where the BOP community has actually placed individuals on the Suboxone program prior to release. So as they transition into the halfway house, they are already on Suboxone. So Be Well has definitely been a great program for us to follow up with individuals who continue that regimen. And we've seen a lot of success with Suboxone and Trexan, and of course, anabuse.
Dr. Kalansi, go ahead.
Thank you. I'm excited to hear that you do Suboxone and not methadone. So two questions, because now that's come up. Who pays for the Suboxone? Because it does free up the patient from having to go to a clinic all the time, and the golden handcuffs, right?
Right.
Traps them in that system. So that's exciting to hear, actually. But one, who pays for that? And then you mentioned the housing, like how close are those to the communities where they live so that they can acclimate to you mentioned that getting a job and adjusting and everything, but if they are 20 miles away and then when they move out they've disrupted their community, like how do you where are the facilities at that they live, and how do they how do you pick those?
Sure. Well, your first question, who pays for Suboxone? So in the BOP, they are given the medication for free. So as they acclimate back into the community, Be Well has actually been a vital artery for us, where individuals are actually getting that medication at an income scale level. So they're able to afford that. So that has been a benefit. If we find that the individual cannot afford that, then of course we want to transition them over to River City through the Trexan program, which then the federal government will pay for that for them to keep them clean and sober. When it comes to housing, individuals, we want to get them placed immediately in a work environment. So Goodwill has been our partner, which they provide OSHA programs, they provide careers on demand to get them certified, like in HVAC, construction, plumbing, jobs that are going to give them sustainable living income. And as they are going through that program, they get a stipend to live on. The U.S. Probation Office also does have second chance funding, where we will offer them bus passes in order to get to and from their treatment programs. We also can help financially for 90 days rental assistance. That is the deposit, first month's rent, and then 2 months additional rental assistance. So we then will sit down, we'll collaborate with the individual, because we don't want to set them up for failure. We want to ensure that they have the job and they can be able to pay for that rent. So we want to meet them wherever they're at and ensure that this is going to be a successful collaboration in order for them to be successful with the apartment complex. We do have apartments that are felon friendly. So that helps a lot to get individuals into apartments where they can feel like they have worth. They're able to pay their bills, they're able to get to and from their treatment programs, they're able to have a sustainable career and feel that they have worth inside of them. That is the most important thing. I hope I answered your questions.
Yes, thank you for that. I appreciate it.
You're welcome.
Johnny, go ahead.
Yes, just a quick question, because you talked about supports. So are individuals that are on probation, federal probation, are they connected with recovery coaches and peer support services? Are those referrals that are made?
Yes, actually, Lifetime Recovery has a peer support program, which once they're in the substance abuse program, they can transfer over to peer support. So they can actually have their own coach for as long as they want to. They can be in that peer support meeting that happens, I believe, every Thursday. And they offer them lunch and they can come on their lunch break, have that peer support meeting, and engage with people that are going through the same things that they are in recovery. So I know Sakata, we've used their peer support programs as well. That way they can engage with that individual because life has its ups and downs. You know, they're going to have issues that are going to happen. And the last thing we want them is to revert back and relapse and then have a full blown, whirlwind of going back to their drug use, whether it's, failure of a relationship or, child custody issues, or it could be, they lose a job. The moment that we hear something happen, we want to be on it with them. We want to discuss it, have those courageous conversations and find where do we go from here? What do we need to do to recover?
Absolutely. Perfect.
And Lindsay, I saw you noted something in the chat. Would you like to unmute and follow up?
I'm just curious as to, since methadone is such a widely, it's considered the gold standard, right? And it works really well. Why is it not offered?
It's so hard to get an individual off of methadone. And sometimes, we cannot monitor that program the way we would like a medical assistant treatment program or Trexan. Officers want to be very involved into how that medication is being distributed, what the dosage is. We want to make sure that they are healthy. At least with River City, when we have them enrolled in a Trexan program, the doctor is constantly every 90 days assessing blood work to determine that their liver is okay. Because the last thing we want is something critical to happen to them health-wise. So we want to ensure their health is a priority for us as well.
And they don't do that in methadone clinics?
A lot of times methadone clinics don't want to staff because they're not a contract provider for us. So they don't want to give us that information. And a lot of times, individuals on supervision are having to pay that out of their own pocket. And the fees can be, they can start at $50, but then by the time you know it, they're at $300-400. And a lot of times they can't afford that even in this economy. So we want to make everything realistic for them. And we want them to survive, and having their own sustainable housing, if they have to pay child support and that's coming out of their paycheck, looking at this from a big perspective and looking at something that's going to create success rather than failure.
I get it. Thank you.
Absolutely.
Great.
I'd
Susan,
like to make one. I wanted to make one comment. Is that possible?
yeah, go ahead.
That question that the young lady asked a few minutes ago, I think the feds have come a long way because I remember when I first started, there was a condition that said that totally restricted methadone use. And we had to deal with that, but I think the key issue is that for the most part, the officers, if the person wants to do methadone, the officers are not going to say, you're not going to do it. It's just easier for us to help someone through a process that is accepted by the federal, by the courts. And so sometimes we have to battle between those two. So we try to help the individual go with the program that is most successful for them.
Okay, I'm sorry. So you don't kick them out if they're on methadone?
No, but sometimes
Oh.
they get themselves into a pickle, and they're paying $300-400 in methadone, and then they don't know how they're gonna, get treated the next following week. And then we have to look at, okay, how do we correct this? And it's weaning them off the methadone to transition them into, whether Suboxone or a Trexan program to actually, get them off that issue that they're spending so much money. They're spending all their paycheck in that.
This is Brennan Del Pozo. Thank you for the presentation. It's interesting that we're diving into the problems with methadone, because methadone is a more effective treatment in every clinical study than naltrexone. And we're finding that with fentanyl, some people find it more effective, particularly for fentanyl dependence than Suboxone. And one of the reasons why it's harder to use in supervision in carceral settings is just the way the federal government has regulated it, right? Suboxone is very lightly regulated in comparison, and even less so than before. And so the fact that they're spending all this money on methadone, I mean, may well come from the fact that their physician and them think it's a superior treatment for them than Suboxone. And yet they can't get the coverage for it because of the regulations and everything. It's just something, the most interesting court research I've seen and supervision research is settings where the court says quite sensibly, we're not physicians, we're not addiction treatment providers, we're police and probation and parole and judges. We're going to let doctors decide how to treat these people, and then we'll meet the doctor's expectations with the best care. It would be wonderful to see that being the guiding principle more widely. And the last thing, you said something that caught my ear, which was something about needing a plan to get people off methadone.
Right.
The best clinical outcomes for all-cause mortality are people being on medications for opioid use disorder for at least 5 years. So
Right.
if you're talking about like getting them off after 5 years, I could say, well, if you've reached the point where the research says you've gotten most of the benefits, but if you're trying to pressure in any way. I'm not using the word pressure. I don't mean to sound pejorative. If there's like institutional pressures or normative pressures or family members or probation and parole officers with opinions trying to get people off of MOUD when they're like, hey, I'm not ready for this, or it still matters to me, or my doctor says I'm not ready. Unless you're talking about years and years and years, that's probably not the standard of care. And I know this is all evolving, but I'd urge folks to take that seriously.
Yeah, and we do. We try to meet them where they're at. And we have very few offenders on methadone. And the few that we do have, definitely the officers are definitely working with their physicians to ensure, or the clinic that they're working with to ensure that a lot of times they're using methadone and then they're using the street drug, to ensure that they're only using methadone. So it's very few, but I think the BOP has done an exceptional job of getting people that are opiate dependent on Suboxone, and then if individuals have those urges and cravings and we present the Trexan program to them, definitely they're amenable to it. So I know when I started as a young officer, we were always told, so methadone was not the way to go. Our office did not approve of that. So we're seeing some transition, but not very much. The pendulum has not moved very much on the government side of it.
Yeah, the last thing I'll say, because I see there's hands up, is I think I'm applauding like Suboxone in a supervision setting is excellent. I don't mean to diminish it, and it's years ahead of where we all came from across the country, so that's great. I'd urge folks to look at the research on naltrexone. It's a vastly, clinically, it has vastly inferior outcomes. So I just urge folks to look at the medical research on.
And you know what? Let me add to that, because when we first started Trexan, or naltrexone hydrochloride, which is the trade name is Trexan, it's from the 1980s. And when we brought it in back then, that was the only thing we had that was working. When we found that naltrexone hydrochloride changed to Revia, which was a study done with the veterans, the VA, where it helped with people that had alcohol dependency, and it reduced the cravings in that area. That was something that was a positive, right, for it. But what I'm happy about is that the federal system has moved a little from Trexan to the Suboxone, which we didn't have back then, thank God. And so we have to always look at, they depend on the contractors to stay up on the research for medication. And Trexan has become obsolete. It is a product from the old days, and we have to move on to the next meds, which is the Suboxone. Thank God that we're doing that in the federal system, and then hopefully other medications that are going to be more helpful for individuals based on the research. And I agree with you on that, Dr. Del Pozo.
Fought Suboxone, Cindy, back in, when I started in the early 2000s, they fought us on that. And the individuals that you see that are on it have maintained sobriety, which is really nice to see.
Great. Susan, I see you've had your hand up for a moment. Go ahead and unmute and ask your question.
Oh, hi, I'm Susan Yerkes. I'm with the Bear Area Harm Reduction Coalition. And so, we see a lot of our clients are coming out more probably out of jail than out of prison. But and I'm really interested in raising the consciousness of the jails in terms of treatment. But what you're doing, that the continuum of care that you're giving is just, I mean, I find it's really amazing. We're just starting a resource arm of our syringe exchange and wound care. We have a doctor and some folks who are there for wound care. But I wouldn't, I'm taking notes like crazy, but I would to, you may be too busy, but somehow see uh, the different resources that you're using, because I'd really like to be able to refer our folks who are just sick and tired of it,
Yeah.
if they don't have a probation officer, which would be terrific, but I'd like
Yeah,
to
I'd be happy to sit down with you and discuss, even programs in the community. I encourage officers to stay abreast of what's happening in the community, what free programs they are, even if it's a sliding fee scale, if we could get them in there for $5, we can pay that somehow for them. It's essential that these individuals that come out back into the community, that they have a support system that's going to benefit their future. And definitely sometimes they lose that family atmosphere. And so their probation officer becomes the go-to for them. And I think that's essential in building a strong foundation for them to engage in positive programming through supervised release or probation and get them to the finish line, whether it be through, finishing their supervision or early termination. So definitely we want to provide the court those positive things that individuals do as well.
I'm really thrilled about that. Could I get your
Absolutely, yes. I put it in the chat, so it's in the chat on Corrina Lopez.
Great. We love to see all the collaboration. Dr. Clancy, I want to give you a quick moment before we move on to the announcements. Feel free.
Thank you. I was going to agree with Dr. Del Pozo that naltrexone has very poor outcomes, right? But it is more acceptable because it's not a controlled substance. But I would also suggest that even if patients do better on methadone, if they are trapped by having to be at a clinic at 5 a.m. and wait in line and get a dose, it disrupts their life. And that's, even as a pharmacist, I recognize that is at the barrier to them continuing with treatment. But in Texas, Medicaid pays for methadone, right? That's the problem. It doesn't pay for Suboxone. So there's so many variables here. And I'm really glad that you gave this presentation. So thank you very much.
Oh, thank you so much.
Thank you to everyone. And in the interest of time, I'd like to go ahead and move on to announcements. Cato, if you could please, thank you. All right. So to claim your CEU credit, you must complete the post-session survey in the chat or by email. Send after this session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you do have any questions, feel free to email bewelltexas@utesca.edu. And remember, when you complete our post-session survey, you help shape these sessions around your needs. We created this series for you, and your feedback truly matters. Your ideas, experiences, and suggestions guide how we plan future sessions, what topics we cover, how we deliver content, and the kind of support that we offer. Please take a moment to complete the post-session survey. We're listening, and your input helps us make this ECHO series even better. Next slide, please. So you have a difficult case that you or your team have encountered. CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and fellow providers who understand the real-world challenges you face. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. By sharing your case, you'll gain expert clinical guidance, supportive peer learning, and evidence-based resources tailored to your case. To submit your case, please email us at cstat@utesca.edu. Next slide, please. The Texas Substance Use Symposium is back March 2nd and 3rd of 2026 in San Antonio, Texas. For the latest updates, please visit the txsus.org. Next slide, please. Please join us for our next Public Safety Solutions for Substance Use Disorder ECHO on Thursday, November 13th at 11 a.m. Central Time. Thank you so much. And let's go ahead and move on to our case presentation for today. Kato, if you can bring up the case form. And Johnny, feel free to walk us through the case. I think you're muted, Johnny.
Oh, can you hear me now?
Yes.
Okay, good. Thank you. Sorry about that. So again, I'm Johnny with Abilene Recovery Council. Really great presentation. My mind is just exploding with thousands of questions. But for interest of time, I really want to kind of get into it. And so I'll start with the questions that I'm going to be asking to answer, but certainly if you have any other questions, feel free to ask them. So what I'm looking to have answered throughout as I present this case is, what could I have done differently? What alternatives to incarceration might have provided a better outcome? Does the sentence in this particular instance, in your opinion, fit the offense? And how do we advocate for more sensible sentencing, at the local level, like really getting involved with the local courts? And so in this situation, in the case, the encounter, the setting was the county jail, where as a coach, I provided reach-in support for a 39-year-old mother of 3 children who was arrested for possession of drug paraphernalia, in this instance, methamphetamine that was found in old used baggies from substances that she had already used or ingested. So she was arrested for that, but ultimately she was charged with intent to distribute. And I just recently learned 2 days ago, sentenced to, unfortunately, 15 years for that. So what strategies did I employ to manage this encounter? From the coaching perspective, we always go in, it's person-centered, connection, empathetic and active listening, very trauma-informed care to establish safety and trust. Really wanted to affirming recovery practices. I wanted to really acknowledge this particular person's lived experience and unique circumstances. And so, and also, in ways that we was able to do that, or that I do that, is leverage my own lived experience to foster mutuality and encouragement and rapport. So what are the question here's asking, what are our agency standards? So our standards align really with the peer support model. So we're going to be, competent, person-centered recovery and focused support. Really trauma informed and culturally responsive. And of course, adherence to our agency policies and ethical standards, because, we don't, even though we want to connect with people, we want to make sure that we're not crossing boundaries and sending mixed messages. So in this particular case, methamphetamines and alcohol were her drugs or substances of choice, but the methamphetamines in particular is what got her into trouble. And so when we're looking at some more context about this individual, she has a history of a childhood trauma, PTSD from an abusive relationship. As a child, she was diagnosed with depression, anxiety, and other long-standing patterns of emotional deregulation, which have impacted her daily life and substance use related challenges. She does have a past nonviolent justice system involvement related to substance use in a different state, and she currently has no family support or community support in Texas. Some of the barriers were obviously, our meetings, were in a jail setting, so we had limited privacy and confidentiality. And then there was, the ongoing anxiety that she had related to her unknown legal outcomes and the uncertainty that she had about me as a coach. I mean, she was wanting services, but she really didn't know me. She doesn't trust systems and, didn't really know kind of where to go with that. And then, also sustaining connection with her family. 'Cause as I said, she's from another state. And so her access to family, especially with her children, was very, very limited. And then, accessing, additional community supports was also a barrier for this person. Um, Things that I think that did go well was that ultimately we were able to establish trust and rapport. And I was able to really engage with this peer and get her to kind of open up about what's going on with her. Um, Over time, she utilized some of the recovery materials and resources that I recommended to her to develop um, emotional regulation practices and coping strategies that she can use while she was incarcerated, and also just in life, just really learning how to kind of weather the storm and using those tools. Um, and also, she talked about, in our last conversation, she talked about feeling supported, understood, and hopeful just by having that reach in support, which was very, very huge. Um, and so, what would I do differently? Um, I would, engage. I would, if I'm looking back on it, I would engage directly. I would engage directly with her attorney and the district attorney to ensure, timely communication and really to be able to take a deeper dive and highlight recovery support services and how we could have assisted her with our agency in community-based solutions versus incarceration. And I definitely would have identified more community resources and been more vigilant in garnering community support that could have advocated for this individual. Um, in terms of success, I think now looking at that she has this 15-year sentence that she's going to have to go serve. Success would be continuing to provide the emotional and peer support that she needs, and until she doesn't really need it anymore. So meeting her at the jail, carrying that support into the institution, and really coaching her through that process, and also educating her on the programs that are available in TDC that can assist her with her recovery and her mental health to ensure that she has long-term success in recovery. And then really leveraging my lived experience to prepare and assist her in navigating life in prison, both mentally and emotionally. I was incarcerated for 17 years. I know what goes on in there. And so I have a lot to offer to her in terms of really how to navigate that process and really get the most out of that time. um, and then so referrals, pre-sentence, I did refer her to a community-based recovery program and reentry housing here in Abilene, where I'm at. They were going to accept her into their program. They have a long-standing history of success. Unfortunately, the courts weren't willing to go that route. So now post-sentence, this is like non-traditional referrals. We don't think about referrals that way, but I do. And so, I'm going to talk to her about the recovery programs that are now in TDC that weren't there when I was there, such as recovery housing dorms, health and wellness dorms, sober living dorms, and just a numerous amount of programs that she can really take advantage of that will really help her mentally, emotionally, and with her substance use challenges. And then, really discussing with her, about vocations and because the recovery coaching certification program that they have there, because she talked about really wanting to get into what I do, so there will be opportunity for her to be able to do that. And things like the prison entrepreneur program, which is a long-standing program that has, like, I believe a less than 5% recidivism rate for the people who enter that program and come and re-enter the community. So yeah, so that's kind of what I have going on, and really just kind of wanted to bring it to the table and open it up for discussion.
Let me ask,
Great.
sorry to monopolize the conversation. Was this a woman of color?
No, ma'am.
She was a white woman?
Yes, ma'am.
Wow. Okay. So I just want to say that number one, 15 years is garbage. That's terrible. Two, just recognizing that people from communities of color end up in jail longer or prison longer. And so assisting them more is really a priority on my side, and I'm trying to figure that out. But then also three, I've worked with one of the organizations I work with. They actually have a class where they teach people how to interact with the police better so that they have better outcomes. And I will tell you, when I was a police dispatcher and we were overstaffed, which is very rare,
Right.
if you know, if there was stuff found, but the person wasn't being, a jerk to the cop, then they crushed it and threw it away. They didn't do anything about it. But
Right.
if they did even a tiny infraction and they were being a jerk to the cop, they were more likely to go to jail. So teaching people how to interact with the police in a safer, more respectful way improves the outcomes and prevents situations like that. And I'm so sorry for this woman, because yes, she's going to go through a lot of trauma, and that's and I'll also say this: the things I have done in my journey way exceed what you described here. And I stayed out of prison because I came from a privileged family and I'm a white female, and that makes me so mad. And so I'm so motivated to do the thing, but it's a systems thing. And then also, I also say this: in smaller towns, like you're saying, Abilene, you're more likely to have bigger consequences than big cities that are too busy to do anything about it. So that's also important information.
Well,
Thank you.
thank you for your feedback. And you touched on a lot of things. You're right. She already has trauma, and so that's one thing we were really, really working on. That was one of the main reasons I was going there consistently, just to really support her through that. And she was in a town outside of Abilene, which is even smaller than Abilene. And I didn't that maybe play a role in why she was sentenced, so much. And it is very unfortunate. I don't agree with the sentence, but we are where we are. And the way I focus my mind is, as a coach, is okay, well, I'm solution oriented. So I'm asking myself now, how am I going to be able to help her now? And so I'm going to ramp up my reach and support, and I'm going to, ramp up my efforts to galvanize others in the community also to reach in and support her. And I'm going to share with her everything that I know about the prison system so that she can have, the best experience possible, if that's possible.
Thank you so much for bringing this case to us, Johnny. Again, I would like to open up the floor. If there are any other questions for Johnny on his case or the patient, feel free to.
There was a couple of questions that we had before the session, and that was the possibility of an alternative sentence you mentioned in one of your questions. And I was wondering if there was any opportunity to be able to maybe bring up to the attorneys possibility for residential treatment before the person goes for sentencing, that maybe that might, persuade or sway the judges to consider a lesser sentence or to mitigate the sentence that she got.
Sure. I connected her with an organization here who works with women, incarcerated women who are reentering the community. They were going to accept her. I mentioned this to her attorney. I sent a letter to the district attorney and mentioned it. And I also discussed with them, other alternatives, to incarceration. And I explained to them, all the services that we have here locally that are available to her, how that could benefit her. But even I went even further to say that, hey, look, if that's not a viable option for you, I talked to them just a little bit about the programs that they have within the system. The IS the
Safe P?
the safe P programs. I'm sorry,
Right.
safe P and SATF and all these programs, and asked, hey, could these be utilized effectively to maybe really help, this
Right.
individual, and let's not just throw her away. But unfortunately, those just weren't options for whatever reason.
They didn't give you any reasons for that?
No, ma'am.
Lindsay, I see you posted some questions in the chat. Do you want to unmute?
Oh, I just wanted to clarify that she got 15 years for like a paraphernalia charge.
Right. So what happened is she was moving, and she was moving from that small county to Abilene, and she went to the house and she had packed up all her stuff, and she had some trash, and those in the trash it contained packages of old packages that had some residue of methamphetamines in them that she had already used, and so that was mixed in, with the trash. And so she, when she got pulled over, I forgot the reason she got pulled over. When she got pulled over, um, and they searched her vehicle and they went through the trash and they found these baggies. What they then did was they took whatever was in the baggies and they combined them all together, and that's what they used to increase the weight um, of what they said she possessed, and then that's what they then charged her with. Which, by the way, is illegal. So in Texas and in a lot of states, so you can't really, argue against that. I think it's kind of bummy that people can do that, but that was the instance in this particular case.
And I will throw down that the testing that police use roadside is not always accurate. And then it ends up being the responsibility of the individual to prove that it's something else, and they have to pay for that. And if they don't have the money for that, then they're trapped.
Right. In this particular instance, I mean, she owned up to it. She tried to explain to them that, hey, this was some old stuff. It was in my trash, and she actually was transitioning to Abilene to come to get into transitional housing so that she can go to treatment. And just unfortunately for her, the stars just did not align, and she got pulled over, and everything kind of just went left from there.
Which is why training people how to interact with police is really important, because they have rights. And if it was me, I wouldn't have said anything.
I mean, well, they searched her car, and I don't know what the reason for the search was, but they searched her car, and when they searched her car, they went through the trash, they found the residue, and like I said, she doesn't really have any family support. She didn't really know how to advocate for herself, and just really it was just unfortunate to not really have any support or any answers or know what to do, and just she just got she just got wrong place, wrong time, and I get it. We do have to be held accountable, for the things that we do. I just feel that in this instance, and in a lot of instances similar to this, that there has to be better alternatives than long-term incarceration for people who are struggling with mental health and substance use.
Thank you so much for those great points. At this time, I would like to call for any final questions that we have for Johnny on his case or his patient.
Just real quick, have you reached out to maybe to like the Innocence Project and see if there's anything that they would suggest like to do legally to help out?
No, ma'am. I have not. This sentence was, she just got this sentence like 2 days ago.
Yeah, that might be like an avenue to call and see if you can get some help, or not you, if she can get some help with the sentencing and stuff.
Yes, ma'am. I will definitely mention that to her. Thank you for that feedback.
Thank you all so much for that great participation. With that, I'd like to move or get our summary recommendations for this case. Cynthia, can you please give us a summary for today?
Yes, thank you. So we had a lot of issues today that we discussed. There's a lot of challenges with the systems, the criminal justice system, the court systems. The important things is that reentry is really essential and important for the success of individuals that have been incarcerated and coming out into the community. We're seeing that probation officers are trying really hard to wear the different hats and to ensure that they meet the person where they're at, matching them with the services that will be helpful, not using the cookie cutter approaches, the cookie cutter programs out there. And also, we hear that there's challenges with, not staying up with some of the research, which is really important on some of the medications that are becoming obsolete, some of the medications that work, some that don't. There's also those are our challenges and concerns. There's also concerns with our case presentation where we see that there's some injustices in sentencing situations with individuals that have, substance use disorders and problems, and how smaller locations as opposed to the bigger locations as far as the metropolitan, the cities and smaller counties where, there's some bias happening, and we see it every day. We see it in all our circumstances, and we try really, really hard to navigate through some of those and build those treatment services and resources for people. And our goal is to help them to be successful in whatever way we can, whether it's through the jails, through the prison systems, through working through the criminal justice systems. But all in all, we're all doing our very best to try and help individuals to be successful out in the community with our recovery support individuals, with the ties and that we have out in the communities, and collaborating and bringing all those together to develop a treatment system for an individual to be successful. And thank you, all of you, for the work that you do.
Thank you so much, Cynthia. And thank you all for joining today's ECHO session. As a reminder, if you would like to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the Be Well Texas team at bewelltexas@utesca.edu. We look forward to seeing you at our next session, and have a great rest of your day.